San Diego, January 2022. It is a new year, and it is time for NAEMSP, the National Association of EMS Physicians. Together, at last, we can have our annual meeting. It's been 2 long years since we've seen each other in person, and just coming back from this conference, I can tell you that has been way too long. Oh my God, I have so missed seeing my friends and colleagues. Listen, I think most of y'all probably know that NAEMSP is the place to go if you have an interest in EMS research. And let's face it, if you're listening to this nerdy podcast, you have an interest in EMS research. Well, there was, as usual, lots of great research presented. And I got a chance to sit down and interview some of these researchers. Stay tuned to hear about the great work they're doing.
What is a lighthouse? It is a tower with a bright light at the top, located at an important or dangerous place. The main purpose of a lighthouse is to serve as a navigational aid and to warn of dangerous areas. Welcome to the EMS Lighthouse Project podcast, illuminating the darkness of current EMS clinical practice with the bright light of science. Here's your host, Dr. Jeff Jarvis.
Howdy, y'all. I'm Dr. Jeff Jarvis. Welcome to episode 54 of the EMS Lighthouse Project podcast. This is going to be a 2-part podcast, episode 54, and then again, episode 55. So much great information, we had to break it up in half. It really was great to see everybody back after 2 years. One of the things that was really special for me is I got to meet a lot of our listeners, and I really want to thank you for listening to this pod or watching these videos. When I make these, I am just sitting in a studio all by myself, talking to a camera and this microphone up above me. I never know that people are listening, so when I get to meet you and I hear that you're interested in the same things I'm interested in, it is really rewarding. Thank you for your support. There was so much great research presented at this conference, and I'm not even talking about the program itself. That was amazing. Such great speakers. I got to interview some of the folks who are here, but I didn't get to interview nearly as many people as I wanted, and that is a function of my limited time and limited organizational skills. Before we hit the interviews, I want to thank my photo assistant and budding videographer. We have been working together for 30 years. Okay, so thank you, Christy, my wife. You did an amazing job putting up with me, walking around, filming our videos. Thank you so much for helping out. You are, as always, amazing, and there's no way I could do anything without you. Thank you, and I love you. Was that better? So we have 4 great interviews for you on this pod. We're going to start with Dr. Amber Rice talking about the secondary analysis that she has been doing on the EPIC study with traumatic brain injury. We're going to talk to Dr. Veer Vithalani about how he is using data at his system in Fort Worth to safely dispatch BLS units based on historical call data in what used to be an entirely ALS system. Then we're going to talk to EMS fellow Dr. Erin Lincoln about disparities in analgesic care. And we're going to wrap it up talking to Dr. Henry Wang about a secondary analysis of his PART study comparing King LTs to endotracheal intubation in cardiac arrest. This is a great episode. Let's hit it with Dr. Amber Rice from Tucson, Arizona. Dr. Amber Rice, you're an emergency physician and an EMS physician in Tucson, Arizona, and you're involved with the EPIC study. You just presented an oral abstract at NAEMSP looking at the impact of hypotension on patients with outcomes. Thank you very much for talking to us. Do you mind telling us about your work?
Yeah, absolutely. So this study that I presented today was actually a reanalysis or a sub-analysis of the original EPIC study data. So we looked at the pre and post implementation cohorts for the original study, and we looked at hypotension, And what we were looking at is whether or not pre-hospital hypotension or in-hospital hypotension, if there's a difference in mortality with those two different time periods. And so what we had done is separated them out into groups that had either no hypotension, either pre-hospital hypotension, or in-hospital hypotension, or both pre-hospital and in hypotension. And really what we found was that the folks with no hypotension had the lowest mortality and the lowest odds of death. Okay. And those that had pre-hospital hypotension had a dramatic increase in their mortality and odds of death. And those with hypotension in the hospital, so that if their initial blood pressure at the hospital, even if they weren't hypotensive in the pre-hospital time period, if they arrived hypotensive to the hospital, that was an even more dramatic increase in mortality. And those that had hypotension that started in the pre-hospital time period and wasn't resolved before they presented to the hospital, those had the highest risk of mortality.
So we're looking at two variables per patient: pre-hospital hypotension, in-hospital or arrival hypotension. And it's really, really bad if you're hypotensive in the field, it's not corrected, you're hypotensive upon arrival. I'm assuming the best outcomes were you're never hypotensive.
Correct.
And then, so there are two other groups. Just logically, there would be pre-hospital hypotension resolved, and then no pre-hospital hypotension, but they became hypotensive on ER. And can you tell me again what the results there were?
Yeah, so essentially, the more proximal your hypotension occurs to when you arrive at the hospital, the worse the outcome. So if your hypotension occurs early but is resolved, that's worse than no hypotension at all, but not as bad. And then if you're not hypotensive, but then you start becoming hypotensive, that's even worse. And if you have hypotension that doesn't get fixed, that's obviously the very worst.
Interesting. Well, that last group I think is we get that. That's a marker probably for severity of injury.
Yeah, absolutely.
What are your thoughts about those middle two groups? I think they're hypotensive always. Maybe that's just peri-arrest. They're really bad. And the no hypotension, those two groups kind of make sense to me. The ones in the middle are really interesting. What do you think? Do you have any explanations for what you think is going on there?
I think it's probably more the trend, right? So if we look at the trend of blood pressure going up, that's better. Yeah. If we look at the trend of blood pressure going down, I think we're just looking at the trend. So it's someone that's trending towards a worse blood pressure and then subsequently a worse outcome.
Makes sense. So part of the EPIC guidelines is, so EPIC was a before-after implementation of quality improvement, if you will, of a statewide initiative. And part of it was avoid hypotension, give fluids. So this seems like that would support the value in those guidelines.
Yeah, absolutely. I think that for sure being able to treat that hypotension or being very intentional about treating hypotension is very important. In the rest of the study, what we had looked at also was the near hypotension. So if you look at the previous results from the EPIC study, you'll see that the best outcomes aren't with a blood pressure just greater than 90, but the outcomes continue to improve all the way up to a blood pressure of in the 130 to 140 range. And so not only is hypotension bad, but near hypotension is bad as well. And so I think that focusing a little bit more on blood pressure just tends to push the patients getting a blood pressure that's a little bit closer to that best value. We're not sure what that best value is exactly, but we suspect it's probably more than 90 or 100.
More than 90, yeah. So you were just using a blood pressure. It was not age adjusted, is that right?
So we did adjust for all significant confounders. And even after adjusting for all the confounders, we still had a significant increase in odds of death and mortality related to these same groups. So in that same order, so you had the odds ratio for death in that last group with the hypotension before and in the hospital was 4.4. So there still was a very significant increase in mortality associated with that, even after adjustment. The crude odds ratio for death in that last group is
like
13. So very high, but even adjusted was pretty significant.
So I'm curious about adjusting the value for blood pressure itself. So with a lot of things, stroke and other things, we're looking at permissive hypertension for some people with the understanding that if you're 80 years old and you've been hypertensive for the past 70 years, you need more blood pressure. I wonder, have y'all looked at in a future study whether to look at that so using changing thresholds for hypotension?
Yeah, I think that's definitely an interesting question, because we do know that blood pressures are very age dependent in terms of what your normal blood pressure is, what your brain is used to receiving to maintain cerebral perfusion. So yeah, I think that there is some, heterogeneity in that population just because of that factor that you mentioned.
Fascinating. So, Dr. Rice, what is your tweet? If you get one tweet, let's go with the original tweet. So, really short, what is your tweet to encapsulate the results of this study? What do you think the takeaway message is?
If your patient has a head injury, so in head injured patients, do your best to prevent hypotension and prevent patients from trending down. Yeah. So if you see that blood pressure trending down, essentially, this is my explanation of my tweet now, but if your blood pressure is trending the wrong way, don't wait. So don't wait for that blood pressure to trend to that threshold level. If you see the blood pressure trending down, assume that it's going to continue to trend down and start bringing that blood pressure back up and be ready to treat that.
Perfect. I like that a lot. This is one thing I worry about is if people are sort of tangentially paying attention and they hear hypotension bad, but they sort of miss the context that our denominator is patients with traumatic brain injury. I just hope people don't confuse TBI with, say, hemorrhagic shock, and this is not the place where we're talking about permissive hypotension.
Right.
Way different population.
Right. Yeah.
Perfect. Dr. Rice, thank you so much. I really appreciate it.
Yeah, absolutely. Thanks.
That is some great work from Dr. Rice and her colleagues down in Tucson, helping us better understand ways the EMS can care for patients with traumatic brain injury. We're going to move now to Dr. Veer Vithalani and take a look at how he is safely dispatching BLS units in what was an all ALS system. Veer Vithalani, Dr. Vithalani, I was just talking about some NAEMSP stuff, and we were talking about, hey, my system just switched to a BLS agency with some ALS fly cars. How do we tell which place to send BLS to versus ALS? And I'm like, first step is you're talking to the wrong person. Go talk to Veer. So tell me what you're doing here.
Yeah, so we've been planning even pre-pandemic to roll out a BLS fleet. We've had it for interfacility transfers for several years, but we've been a 911 ALS service since the inception, sort of in the 80s. I think everyone realizes the science is out there now that there are tons of patients who are safely and effectively managed by a BLS crew. And so what we wanted to do was, rather than take a one-size-fits-all approach and just pick our our Alpha and Bravo calls and say, hey, these are safe for BLS. I wanted to take a little more of a data-driven approach. And so what we did is I went back for 2 years, and I included 2020, but I went back to 2019. And I took individual calls, and I'm going to say that, but in reality, the software sort of analyzes all these calls. And I looked for the presence of one of three things. The first one was what we call time-sensitive critical illness. So that is somebody who got CPR, any sort of assisted ventilation, so that's BVM, airway management of any type, NPAs, OPAs, supraglottics, ET tubes, surgical airways, any electrical therapy, pacing, defibrillation, cardioversion, and in reality for these, it could have happened any time during the call. It didn't have to be immediate. That goes into our time-sensitive critical illness calculation.
You could almost call that a potentially life-saving intervention.
Exactly, yeah. Yes, oh yes. I'll make sure to put that in the reference.
That's right, if you don't mind.
The second was unstable vital signs, and this is a definition I came up with several years ago, and to be fair, they're fairly arbitrary. It's hypotension, low heart rate or super fast heart rate, or low respiratory rate. Keeping it simple and just going for those things that I felt were really needed some sort of immediate intervention.
Okay.
And then the third one was what we called ALS Criteria. And the reason I call it ALS Criteria is because it's medication or procedures or certain primary impressions that inside all of those, we expect an ALS response. So for example, so STEMI is a great one. Stroke, even for us, understanding that some systems could handle strokes with BLS ambulances, for our system, we felt like it should be included. ALS medications, so for example, adenosine is an obvious one, but even BLS medications that we would expect a paramedic to show up on, like nitroglycerin, right? If you're giving nitroglycerin, that patient has chest pain, probably needs a 12 lead, or has heart failure, probably needs a medic. And so that's the sort of criteria that we use to determine that.
So you have a list now of things that need ALS.
Yes, or that our system determined that we want ALS as a service to our patients. So then what we did is I went through and calculated over the last 2 years the rate of each of those 3 buckets, as well as some other things such as the number of incidents, the transport percentage, the lights and sirens transports away from scene, that sort of thing. Okay. And then I set some cutoffs, and so I said, if you had a MPDS chance of having a time-sensitive critical incident of less than 1%, abnormal 1%. Vital signs of less than 5%, and ALS rate of less than 3%, that would be our initial foray into our BLS fleet. So those MPDS determinants are going to be assigned a BLS ambulance, and everything else is going to remain ALS for now.
So anything under 1% gets BLS?
Correct.
Assuming they meet the other criteria.
Assuming they also meet the other criteria. So as you see here, in aggregate, we're talking about a rate of 0.3% of critical illness, 2.3% of unstable vitals, and 3% of ALS criteria. I have a secondary calculation called BLS fallout, which basically aggregates the 3 and says if it met any of those, and that's about 4.7%. And so not inside this paper, but we have outcome data now because we've been running this for over a year almost. And the reality is that rate is actually much lower in truth. And I think a large part of that is because one of the ALS criteria is intravenous narcotics. When you remove that, your rate comes down quite significantly. We have oral analgesics that our BLS providers can use, and I'm actually kind of tempted to include intramuscular ketorolac as a BLS option. That's a thing we might look at. But in general, that's the methodology by which we approach this. And now that our pilot's ending, we've sort of gone back and looked at these same codes and said, are we still meeting those criteria with our 2021 data, or are we not? Again, not on this poster, but what we found is there's probably 4 or 5 of these that have come out now. There are some new ones that can be added in, and then one thing that we're planning on doing is actually taking our our ALS criteria and raising the ceiling from 3 to 5%, because what we found is that in truth, that 3% actually has a little lower rate in reality when you're actually deploying BLS ambulances. And so if we bump that to 5%, we can include more codes, more BLS ambulance responses, but keep the safety profile pretty similar.
So that's the research you have here. I think it's great. As somebody who is doing exactly the same concept internally, I have a couple questions.
Sure.
Where did 1% come from?
1%?
Well, I mean, obviously it came from your butt. The question is what was the process that you used to come by it?
So prior to this study,
I'm trying to figure out how to
So prior to this study, I had a separate one that looked at reprioritizing your entire deployment system based on the critical incident and unstable vitals percentages.
Right.
In that study, we had certain goals we were trying to meet, which was less priority 1 or hot responses, and catching, basically, better sensitivity and specificity of your hot responses, essentially.
Sure.
What we found was that using our system's data, 1% was that threshold by which we were responding to the right number of hot calls, but catching more sick patients. If we raised that ceiling up, we would respond to less calls and miss sicker patients. If we move that down, we would respond to way more calls and catch less sick patients. So to us, 1% was the threshold.
Almost like sensitivity and specificity are inversely related.
Exactly. And so those were our thresholds. And as I sort of mentioned with the ALS criteria, 3% also sort of came from here's where our middle ground is. And as we've started to get real data, we can adjust that.
Perfect. So next question for you is balancing measure here.
Yeah.
You send a BLS ambulance to nausea.
Yep.
And it turns out it's a STEMI, or it turns out it's something else.
Yeah.
What are you doing? How do you look for that?
Yeah. So
how do you find that?
We have some very intense calculations that took me quite a while to show up. To create, which basically
I
look
do have
for.
to tell you, you're doing this in Tableau.
Correct.
Life would be so much cooler if you did it in R.
You know what's funny about that is it wouldn't be a live dashboard that I could share with the.
Sure it would.
Yeah, sure. All right.
Shiny R. There's a package for that.
All right.
Balancing measure.
Yeah.
What are you using as a balancing measure?
So one of the things we actually have, when we set out for this project, when we actually deployed it, we set up a handful of goals. So one of them, there's several. The clinical ones were. Higher ALS skill utilization per medic, so that was one. And the second one was
skill dilution.
to reduce skill dilution. And the second one was essentially second unit responses with ALS intervention. So not just second unit responses.
Not as dispatched, but
as requested. Correct.
Okay.
So I have a metric that looks
that's
at
your catch.
Exactly. If a BLS ambulance showed up and an ALS unit was dispatched afterwards and ALS was performed on that, that's happening about 1.3% of the time. And that's where I expected 3%, I'm getting 1.3%.
That's good.
A couple things that happened that we didn't anticipate that would be good for anyone thinking about a program like this. When you only pick a handful of BLS ambulances, it's hard to deploy them in a way where they're going to be available for the BLS calls. You have to make an operational decision. Do I let a BLS ambulance wait there with an ALS call to get a longer response time, or do I send the BLS ambulance in an ALS ambulance, or should I set up a fleet of quick response vehicles, which we ended up doing a bit of a hybrid of that. The other thing is you have to, at the same time, come up with a criteria set. When should BLS upgrade the call to ALS? We had never had that before. We implemented that at the same time. Awesome. We did it in a checklist fashion, put it in our ePCR, and allowed them to go ahead and use that. And of course, the other thing, especially for a system like ours, where our fire paramedics are credentialed at a different level than our transport paramedics, we have certain cities that are all paramedic fire. What happens when a BLS ambulance responds to an ALS fire city, ALS fires on scene, and the patient requires ALS? How does the transport of that patient work? We've come up with what works for our system. Right. Each system should come up with
clearly an internal thing.
Exactly.
So what is your tweet? What is your
So my tweet is, if you're going to start dispatching BLS ambulances for the first time, don't pick codes at random. Use your data that you have in your charting software to determine which codes are safe, and work with as a medical director and with your operational colleagues, decide what your thresholds are for how you're going to determine which codes they are. It could be that you're happy with a 10% BLS response because you have a whole fleet of quick response vehicles or fire medics. There's all sorts of reasons. So decide your thresholds for your systems, and like everything when it comes to a new initiative, decide what success looks like early and know how you're going to measure that.
Good point. Yeah, and I think that the thing I think is valuable, obviously I'm biased because I think this methodology is really useful, not just for ALS, BLS, which is what you're doing with it. I'm still all ALS, and we're using it red lights and sirens versus not. Same methodology. What codes you come up with, I don't think are the point.
Yep.
The point is your process.
Yep, absolutely.
Outstanding. Well, Veer, thank you so much. I appreciate it.
No problem. Thank you.
Well, let's move now to Dr. Erin Lincoln. She is an emergency medicine resident about to start her EMS fellowship in Dallas. She is going to talk about work she has done with the ESO Data Collaborative, and she's going to talk to us about disparities in care.
Could you just turn that around?
Metal, dude, metal.
It's okay.
Hey, Pickett, you got a white tiger tattoo on your ass?
Not yet. I mean, now that you've given me an idea.
See?
There's got to be somebody in this town that can do one.
Dr. Erin Lincoln.
Hey.
How are you?
I'm good. How are you doing?
You know, we live 20 miles from each other. In order to see you, I have to come to San Diego.
I think that's okay.
Seems odd. So, you just witnessed a fascinating conversation about Dr. Pickett's anatomy and some tattoos. How does that make you feel?
It's a bit disturbing.
It is.
Yeah.
I was disturbed too.
Yeah.
A white tie. I don't know. Hey, let's talk some research, shall we?
Absolutely.
You gave an oral presentation because you're an emergency medicine resident.
Yes.
You need to do some research.
Yes.
You had an opportunity. Tell me about your research. What is it that you were trying to find out? You had a question.
Yeah.
What was your question?
So my question was, how frequently are people in EMS first documenting a pain score in patients with non-traumatic abdominal pain?
Okay.
And secondly, giving analgesia specifically to people of different races and ethnicities?
Awesome. So we're looking at EMS data. We're looking at patients with non-traumatic abdominal pain.
Right.
And we're trying to see, did you do a pain assessment and did you give some medicine?
Yes.
All right. So how did you go about answering this question?
So I utilized the 2019 ESO data set.
Okay.
And essentially went through and determined my inclusion criteria, my exclusion criteria. So people that I included were adults, so 18 and older, not pregnant, no trauma.
Right.
We also set a GCS of 14 or above. Just in case, there was any concern about giving pain medications to somebody who's maybe not entirely with it, concerns for airway, breathing, that sort of stuff.
So you're trying to be really judicious in your exclusion so that you would exclude people who would have a potential reason not to get pain meds.
Exactly. Exactly. We also excluded anybody whose first documented systolic blood pressure was less than 90.
Morphine, if that's one of the analgesics, could cause some vasodilation, hypotension. All right. So those were your inclusion criteria. What were your outcomes? What were you looking for?
So we were looking for, A, was there a pain score documented? And then B, if there's a pain score,
fruit.
If there's a pain score documented, did the patient receive any form of analgesia? So we had a list of all of the medications that had been documented in the ASO data set. Anything that might have had anything to do with pain control.
Got it.
Included ketamine, all of the opioids, even Tylenol, anything PO that could be given, and then looked at how frequently were they given.
All right. So was their pain score assessed, and of those who had a pain score assessed, did they get pain medication? All right.
Yeah. So
which fine.
Yeah. So overall, about 80% of patients had a pain score documented at all. And that was roughly the same across races and ethnicities. In terms of getting pain medication, about 13% of patients overall who met our inclusion criteria got pain medication.
13%. So I'm going to be devil's advocate.
Sure.
And I'm going to say, here's the reason I think it was that low. And I want you to tell me whether you look for that. So I think all of these patients had a pain score of, say, 2. They just weren't very hurt. They weren't in a lot of pain, so that's why you didn't give them pain medicine. Could that be a reason?
Thank you for bringing that up. No, we limited the pain scores to 8 or above.
Okay. So you can quibble about what significant pain is, but I think most people would include 8 or above would be significant, and that's somebody we should be giving analgesia to.
Right.
And you saw overall of those patients with a pain score greater than 8, 13%.
13%.
That's disappointing.
That's overall.
All right. So you had the point of your paper, though, wasn't to see, are we treating pain? Because it turns out we're not.
We're not.
We kind of suck at that.
Yeah.
Are we any suckier depending on the race and ethnicity of the patients?
Unfortunately, yes, we are. Whites and Hispanics had roughly the same rate of analgesia administration. There was a slight difference, but not significant. Unfortunately, we looked at black individuals, non-Hispanic. There was a significant reduction in pain meds given. So
now, how did you do that comparison, for example? Because maybe the black patients had, I don't know, maybe their vital signs indicated that they weren't in as much pain, even though we know that's a crappy indicator. Maybe there was something else. So did you do any sort of, was it a straight comparison, or did you try to control for those other things like a regression or something?
Yeah, so I'm fortunate to have some good help with the statistics part of it.
Who was on the paper with you?
Dr. Crow was on the paper with me. And so she controlled for all of those things. Something about a multivariable regression.
Right?
Yes.
Yeah. It looked like she controlled for most of the things that need to be controlled for.
She did.
And you calculated an odds ratio.
Yes, we did.
What was your odds ratio?
0.61. So black patients are essentially 39% less likely to get pain medications than white people.
So that's really unfortunate.
Yeah.
But it's not necessarily unexpected. It's consistent with all of the other literature.
Yeah.
So Erin, tell me, what was your takeaway here? What's your conclusion?
So my conclusion is, first, we don't do a great job in EMS of giving pain medications to people with abdominal pain, regardless of race or ethnicity. And secondly, there is absolutely a disparity in administration of analgesia based on race and ethnicity.
So what we found is we're not very good at giving analgesia to patients with the racial disparities aside. I think that is a really complex issue.
Absolutely.
That we desperately need to pay attention to. Let's look at the 13% overall.
Yeah.
Because that really jumps out.
Sure.
Why do you think that could be?
So I remember back in the days when you were teaching me in paramedic school.
In somebody else's class, because I would never teach. I got an idea where you're going. I would never teach this. some other instructor.
Absolutely. Well, and it was still taught that giving analgesia to abdominal pain might screw up the surgeon's exam.
Yeah.
And so we can blame the surgeons for that.
Yeah. And the people who were still under the confused notion that a surgeon was actually doing the evaluation of undifferentiated abdominal pain in the ER, which we know isn't it. Erin, thank you so much.
Absolutely.
I appreciate it. Great work. This is
Thank you.
important. We got to figure out this racial disparity thing. We've got to figure out how we can do better.
Absolutely.
Thank you.
Thank you.
Great information, really important point that Dr. Lincoln is making. We have got to understand these disparities so that we can begin to address them. Well, I think y'all know that I'm an airway nerd, and I think you probably know the respect that I have for Dr. Henry Wang and the amount of work he has done on EMS airway management, particularly the PART trial. Well, I got to listen to some really good research that Dr. Wang has done looking at the PART trial and trying to explain the results of that. Dr. Wang talked to us about this work. Let's hit it. All right, so we have Dr. Henry Wang with us. Dr. Wang, as you know, was one of the lead editors of the new NAEMSP Airway Compendium. And one of the reasons that Dr. Levy went to him and said, hey, will you help with this airway compendium is he is Dr. Pre-Hospital Airway. He has done a crap ton of research on pre-hospital airway, including the PART trial, the pragmatic airway resuscitation trial that compared endotracheal intubation to King LT. So the main reason I want to talk to you is you just did a secondary analysis of PART, in part to try to explain that 2.9% improved survival with King LT over intubation. So do you mind telling us about your paper?
Sure. So the main trial found that survival was higher with the King LT than with intubation, but it left us wondering why. You know, what's the magic connection between this plastic tube and the outcomes of the patient? And over the last 3 years, we've explored all of these different factors, all of these possible explanatory variables, but we thought the smoking gun would be ventilation, because the tube is to control the ventilation. Ventilation alters the intrathoracic pressure, it alters the dynamics of the CPR. It's got to be the smoking gun that explains the difference between these two interventions.
Thinking that we would be doing something different with ventilation through the ET tube than we would King LT.
Absolutely. Okay. And 17 years ago, Tom Ofterheide had wonderful data showing that as you raise the respiratory rate, it decreases the blood flow through the heart and it worsens survival. And so we thought that it would be, this has got to be the mechanism that explains this relationship. Unraveling this question is really difficult. So this analysis required examining in a very sophisticated way the CPR process files and the capnography signals that were obtained on every patient. As outside of the trial, all the EMS agencies independently collected this information, and we've been able to link this together with the trial data over the last 3 years. Not only that, identifying the ventilations through the capnography signal is not a simple task. As you know, when you're in cardiac arrest, those nice little square capnography curves suddenly become little ebbs and flows. Right. And it's hard to tell if this is a ventilation or a chest compression or something else. Okay. So we teamed up with some very sophisticated signal processing engineers from Spain. Elizabeth Aramendi's group has become experts in the world at analyzing CPR process files and the ventilation patterns. And so we use their expertise to pull in these files, apply their very sophisticated algorithms, and to, for the first time, assess ventilation in a way that's never been done before.
Perfect. So tell me what obviously the data you're dealing with here is the data from PART. And I'm assuming there was not all of them had data, so you had to limit it just to the folks that had the monitor data. What proportion of the patients in PART had complete records and you could analyze?
So from the 3,000 patients in PART, we found CPR process files in about 2,500. Okay. And when you narrow it down, we came down to about 1,010 that fit the criteria for this particular analysis. Okay. And the requirements were advanced airway inserted successfully, end-tidal CO2 available, and at least 3 minutes of post-airway time with at least 50% of analyzable data.
Okay.
And we set that bar so that any data we were using would be very sensible and usable. This is only possible because of the very sophisticated MATLAB algorithms that Dr. Aramendi's group put together.
So tell me what your fundamental question was here. What were you looking at?
The fundamental questions we were trying to answer were, number one, does the duration of exposure to hypo or hyperventilation differentiate King LT from intubation?
Got it, okay.
And number two, does the percentage of the post-airway time with hypo or hyperventilation differentiate King LT versus intubation?
Okay, so in this analysis, you're not looking at survival. You're trying to identify differences in ventilatory patterns in patients with the intratracheal intubation or King LT, is
Correct.
that right?
We're doing the first baby step.
Yep.
Just understand the differences before you try to assess the relationship.
Perfect.
And just understanding the differences, it can be quite complicated.
Not to mention, I mean, just the analysis, that makes my head hurt trying to figure out how to, it's hard enough doing it when you're looking at an individual file, but to do it over 2,500 files, that's quite the task.
And not to mention, we were approaching this from a very different perspective. So in the past, when people have said hyperventilation, what does that mean? The phenomenon that Tom Aufderheide described 17 years ago by looking at City of Milwaukee data looked at overall ventilation rate. So regardless of the duration of the episode, the average ventilation rate was over, say, 30 times per minute.
Right.
So that's one way to examine hyperventilation on the basis of the overall episode. But we also suspect that there's stuttering episodes of hyperventilation that may be harmful, and likewise, stuttering episodes of hypoventilation that could also be harmful. So very important to try to parse these out.
Yeah.
So imagine a 30-minute strip of capnography, and we need to break it down into 10-second segments.
Right.
We have to do smoothing and averaging over time so that we're not overly sensitive with the identification of the ventilatory rate, and then we add all these things up.
So let's just get to the bottom line. I want to know, are we you said, well, what is hyperventilation? So what was your definition of hyperventilation and hypoventilation?
Hypoventilation was defined as less than 6 breaths per minute.
Okay.
Hyperventilation was defined as over 12 breaths per minute. And we also looked at mild, moderate, and severe versions of hyperventilation.
Okay, very good. And just as a reminder, we're talking about adults only here because the part trial was adults only, so we're not looking at kids.
Yes.
So what'd you find?
We found that overall in this study, about 74% of the patients were exposed to hypoventilation.
Okay.
And about 55% of the patients were exposed to hyperventilation.
Okay, at some point.
At some point,
Okay.
correct. And when you parse it out, the duration of hyperventilation or hypoventilation, once again, we saw very eye-opening results. So for hypoventilation, patients were exposed to about 4 minutes of hypoventilation.
Okay.
And for hyperventilation, they were exposed to about 2.5 minutes of excessive ventilation.
So more hypoventilation than hyperventilation.
More hypoventilation than hyperventilation.
Interesting.
Okay.
So
interesting. Right.
Yeah, and what that tells me is that people paid attention to Dr. Aufderheide's work, and we are trying to not hyperventilate, because that's what, for so often when we started looking at this, people are just going to town, and that tells me that we're at least aware of it and we're trying to do something about it.
So my team members would like to remind everyone that you should actually flip the results around and look at it as the glass half full rather than the glass half empty.
Fair enough.
80% of the ventilations delivered in this clinical trial were within the AHA guidelines.
Well,
that's an astounding accomplishment right there.
So do you know if, well, you do know this because almost like you were the PI on the trial, was there anything in part that required the use of a metronome device or a light device, anything like that?
We did not control any of those adjuncts. We heard in the aftermath of the trial and on the coattails of doing these sub-analyses that a few agencies were in fact using some timers and using other strategies to prevent hyperventilation. But was it systematically emphasized throughout the consortium? No.
And it certainly wasn't part of the trial.
No.
Well, let's get into the bottom line here. Was there a difference in hyperventilation or hypoventilation based on the type of tube?
Well, it's a little bit of a buzzkill because we found no difference
Interesting.
in respiratory rate, duration of hypoventilation, percentage of time with hypoventilation, or duration of hyperventilation, or percentage of time with hyperventilation.
All right.
And so this was a surprise to us. We were sure that this would be the smoking gun differentiating the two groups. Okay. We weren't sure if this was going to explain everything about the trial, but the first thing is see if there's a difference, and we didn't see a difference.
So I seem to remember having this conversation with you because when your paper came out, I mean, my ears were bleeding as I was trying to understand it, and we were having this conversation about whether there would be a difference or not. Yeah, it's fascinating. So if it looks like, and you did say that this is a surrogate measure, is there a difference? Are you planning on going back now and looking at ventilatory rates as a function of survival?
Absolutely. So we do have a linkages, an outcomes analysis planned, and we were going to execute it and present it here at the conference, but we paused to reflect upon what we found in the interim. The first thing that's stunned us is we're not sure what the right definition of hyperventilation is. Meaning, for this trial, we used a sliding 60-second window to calculate the ventilation rate for each 10-second period. And that window slides along. It's a very common technique to smooth the results. Okay, but is that the right approach?
Sure.
Should it be a 30-second window? And should the offset be 10 seconds or 15 seconds or longer? Or what if you don't bother using windows at all? What if you use the individual time intervals? So this exercise prompted us to pause and go back and answer those questions. We actually spun off a second paper, another abstract for another conference we will present at a later time, where we've simulated what happens to these measures as you use different window sizes and different offsets, as well as different techniques, perhaps measuring the individual time intervals instead of counting breaths.
So the cool thing about this is that approach, the things that you're trying to figure out there about respirations, don't just apply to respirations. They absolutely apply to compressions. They apply to pauses because you're calculating those on a running period. So
Absolutely, yes.
That's awesome. So, all right, so let's just real quick run through. Bottom line, in part, 2.9% improved 72-hour survival with King LT versus intubation. It doesn't look like it is because of respiratory rate. It doesn't look like it is because of first pass success, and I still have issues here, but maybe compressions, because there was a little bit of a difference in compressions.
Small amount, 20-second difference. We're not sure if that's clinically important.
It didn't jump off the page as like that's the answer.
We are left with two differences that we saw and reported in the original JAMA paper. There's a 2.5-minute advantage for the LT group. Okay? The airway was placed 2.5 minutes faster than the endotracheal tube. Also, the intubation success rate was much lower than anticipated in the intubation group. It was 51%. Now, listeners, remember, the other 49% was successfully rescued with a King airway pretty rapidly. So it wasn't that these patients were left without an airway. It's that they were practicing what they were preached. If you're having difficulty with the intubation, move as quickly as you can to your rescue parachute.
So the interesting question, and I know that there was a paper that you did that looked at adding in first pass into your regression. And that didn't seem to show a difference with anything but ROSC. Now you look at the paper from Murphy up in Seattle, which was looking at survival rates based on number of attempts, and they showed a very clear difference in first pass success versus everything else. Do you think that that is still alive, if you will, as a potential explanation?
Well, absolutely. If you think about it, what is first pass success? It's a surrogate for, I put the tube in very quickly, and I didn't interrupt chest compressions to do this, and I didn't interrupt ventilations to do this.
Certainly, hopefully.
The pause is really quick. And multiple attempts, you would assume, means multiple interruptions in CPR, multiple interruptions in ventilation. And perhaps in Murphy's analysis, that number of attempts ended up being a successful and effective surrogate for some of those other bad interruptions. I can share with you, in last year's analysis of the chest compressions, we specifically looked at single and multiple attempts, and found there was no difference in the total chest compression interruptions.
Yeah.
So in our cohort of EMS providers, they were very good at resuming the chest compressions between the laryngoscopy attempts.
Well, the other thing, and this pops up again and again and again with resuscitation research, is time bias, resuscitation bias.
Yes.
We know that the longer you're in cardiac arrest, the worse your outcomes are going to be. Perhaps the longer you go without an established airway. I don't know if this is true, but perhaps that's an issue. And clearly, Murphy's data shows when you get a first pass success, you establish ventilations quicker. I mean, this is an obvious thing, right? So if it takes you 4 attempts, it's going to be way on out there. So maybe that's the measure. That's really what's...
That's entirely possible. The longer you are in cardiac arrest, the more opportunity you have for bad things to happen.
Absolutely.
Also, the more opportunity for good things to happen. But, you know, getting back to today's presentation, I think an important concept I would like everyone to really think about is, what do we mean by hyperventilation? Is it excessive rate, or is it the tidal volume, or is it the minute volume? Does it have anything to do with how the body's reacting to the delivery of oxygen or the lack of oxygen? What about the end tidal CO2 value? Is that an accurate reflection of how well the oxygen has been delivered overall? Maybe there are some patients who need a respiratory rate of 20, and that's okay for them. So you see that we can't even decide with today's available technology which of those parameters really defines, quote, hyperventilation. Our analysis is simply the rate.
Right.
Okay? And it's only one part of the equation. There are probably 3 or 4 other variables that you should put in there to get an accurate assessment of what hyperventilation means. In fact, minute volume, rate times of tidal volume, is probably the most proper way to characterize hyperventilation. But we don't have technology available yet to quantify that.
Yeah,
it's coming.
Absolutely.
Okay, and this will transform our understanding of this.
Exciting.
Okay, but I'll be honest with you.
Injuries.
Also for head injury.
For head injuries.
Yes.
Yeah.
But you know, Jeff, the more I think about this problem, because we've been immersed in this for the last 2 years, when you get down to the scientific mechanism, how do I connect airway to the ventilation to the outcome? I don't know if this is the right pathway. And we're not going to give up. We're going to keep digging through and trying to get more answers. But I don't know if this is really the smoking gun here.
You have outlined a lot of things that we don't know. One thing I know for sure is we're not going to get those answers unless we keep looking. So I was really excited to see this poster. I think it helps a lot. Henry, thank you so much. I really appreciate it.
Absolutely. Thank you.
Well, that is all the time we have for this episode. When we come back for part 2, episode 55 of the EMS Lighthouse Project podcast, we have 3 more researchers to talk to. We're going to talk to Dr. Brian Miller with the MedStar system in Fort Worth about some work he is doing with migration or walking of mechanical chest compression devices during CPR. It turns out those suckers move. He has an interesting way of looking at that. We're going to talk to EMS fellow Dr. Sarah Frances McClure from San Antonio about work she has done on attitudes of providers around COVID vaccine as a function of EMS leadership. Does that influence a provider's decision to get vaccinated? And we're going to wrap up with a fascinating discussion on a topic that I really thought we had put to bed. That is the use of sodium bicarbonate in cardiac arrest. Outgoing editor-in-chief of Pre-Hospital Emergency Care, Dr. Jim Menengazi, has some really interesting information to share. So that's it for this episode. Please join us again for episode 55. Thanks, y'all.
You've been listening to the EMS Lighthouse Project podcast, a proud member of the FlightBridge Ed podcast family and a Firedog production. Visit flightbridgeed.com for more information.